Okay, next I'd like to invite Andrew Udi up again. This time he's going to be talking to us about improving antimicrobial use before we reach hospital.
So thanks very much everybody for staying for the afternoon session. It's a hardy group. So I'm going to talk a little bit about an idea which we hope to see move into a clinical trial to look at the trying to see whether there is value in pre-hospital antibiotic administration for patients with severe sepsis and septic shock. And it's a somewhat controversial topic, and hopefully there'll be some questions towards the end. So really this is related to time to antimicrobial therapy. And this sort of data doesn't need any introduction. I'm sure everyone's seen this slide before from over a decade ago now in Ann Kumar's paper, from time of onset of hypotension to the administration of appropriate antimicrobial therapy, almost just too good to be true. The sort of linear response that you're seeing with every half an hour that goes by prior to the administration of appropriate antimicrobial therapy is associated with a 7.6% reduction in your chances of survival. And very widely cited paper, over 1,700 times. There were 2,700 patients in this cohort, and has largely informed a lot of practice around the application of antimicrobial therapy as quickly as possible to patients that are sick from presumed infection. The data are supportive. This was another cohort, observational cohort study, multi-centre, looking at about 18,000 patients from the Surviving Sepsis Campaign guideline, which looked at the time to antimicrobial administration from the recognition of severe sepsis and septic shock. And it demonstrated that beyond 2 hours, a delay of more than 2 hours is associated with an increased risk of mortality. And that increased sequentially up to over 6 hours. There's other data from single centres, such as this in Spain, which looked at when you got appropriate antimicrobial therapy for patients that were admitted to the intensive care unit with severe sepsis or septic shock, and looked at ICU and hospital mortality, and in this case, administration of therapy prior to arriving to the ICU was associated with a reduction in mortality. It's obviously confounded by the fact that patients are going to get sicker over time, so that if that may have contributed to some of these findings. But all of these data are observational, retrospective in some cases, suggesting that there's benefit from early application of antimicrobial therapy. Then there's a meta-analysis which is performed 2015 by Sterling and colleagues, which looked at 11 studies, some of the largest studies that observational data, looking at the time to antimicrobial therapy. The box A is looking at whether or not you received antimicrobial therapy within 3 hours of triage in the emergency department with severe sepsis and septic shock. Triage from the emergency department, and then box B is looking at whether you received appropriate therapy within 1 hour of the recognition of severe sepsis and septic shock. The point estimates there all suggest that there is a signal towards an improvement in outcome, but the confidence intervals cross 1. So the authors in this particular paper suggested that there is no evidence to support those particular time frames of 1 hour from the recognition of severe sepsis, septic shock, and 3 hours of ED triage. They don't say that antibiotics early is not important, but they say that those definitions are not data driven, and particularly in the United States, you get penalised if you don't meet these particular targets. So that's interesting. And then there's this work which is from Maren Koloff and colleagues in the United States, which looked at 500 Enterobacteriaceae isolates from blood culture in patients that all had positive blood cultures of Enterobacteriaceae in patients in the intensive care unit. The clock started ticking from the time the culture was taken, and then they looked at survivors versus non-survivors and those with sepsis, severe sepsis and septic shock, and found no statistically significant difference between survivors and non-survivors. So What's going on there? So, we've got a lot of observational data. We don't have a randomized controlled trial of antibiotics versus no antibiotics. That's just never going to happen. It's really, there's not equipoise on that issue. But is there an opportunity to try and explore this particular issue of timing of antimicrobial therapy and whether perhaps earlier administration of antimicrobial therapy is of benefit? And we have to assume one thing, which is that initial antibiotic therapy and hitting hard early has got to be a good thing. And I think if we make that assumption and we suggest that that's going to be a good idea, then we have an opportunity to look at this in a different setting outside the hospital. This is a landmark study, which was performed here in Australia and New Zealand, the ARISE study. Of course, I paused to present this here with one of the chief investigators and primary author sitting in the audience. But this was a landmark study of 1,600 patients, which was performed throughout Australia and New Zealand, looking at early goal-directed therapy for severe sepsis and septic shock. Patients randomised either to standard care or the use of the catheter and protocol for resuscitation. What we looked at here, first thing is to say is that the overall mortality in this group of patients was 18.7%, so around about 20%. So 1 in 5 patients dying from severe sepsis and septic shock in Australia and New Zealand. And the time to the initiation of antimicrobial therapy in this trial, and remembering that I suppose these are emergency departments which are on the lookout for patients with severe sepsis, septic shock, because they're going to enrol them in this study, was 70 minutes in the EGTT group and 67 minutes in the usual care group. So perhaps an hour from, if you wanted to round down, maybe slightly longer. I would imagine, and I think it's going to definitely be the case, that outside the study, the time to antimicrobial administration in patients who are arriving to our emergency departments is going to be longer than that. But even if you say 60 minutes, data from unpublished data from Ambulance Victoria suggests that there's probably 20 minutes or so spent probably at the scene of patients where they're being transported for severe sepsis. There's probably another 20 minutes or so at least of transport time, maybe slightly longer if you were in a regional part of Victoria, and then there's at least going to be 5 to 10 minutes of handover, and then there is going to be the ED workup. So you potentially, from the point in time that the patient first interacts with a healthcare provider, which is the paramedic, through to the administration of antibiotics, maybe up to 2 hours. And whether we can leverage that to see whether there is actually a benefit from earlier administration of antibiotics is something that we're interested in. This is data from King County in the United States, where Chris Seymour and colleagues looked at the number of emergency medical service attendees with severe sepsis, and this is the dark line here is looking at those with severe sepsis, whereas the 2 grey lines are stroke and acute myocardial infarct. So patients with severe sepsis, septic shock are being transported to hospital more frequently than those other conditions by ambulance staff, paramedic staff, or emergency medical services, and that number is increasing. The other thing about these patients that end up arriving in our emergency departments via ambulance is that they tend to be sicker. They tend to be slightly older. This is a single centre study, again from the United States, but it suggested that the SOFA score is higher in those patients arriving via ambulance, and they are older. So this is a sicker group. There is a significant number of them which are arriving to our emergency departments. I put this picture up because the difficulty with this type of research is that there, in the pre-hospital setting, there's a number of imposters, and making the diagnosis of severe sepsis in the community or in the pre-hospital setting is going to be difficult. The recent definitions for severe sepsis, septic shock have been released, and I'm sure everyone has seen these papers. And the Q-SOFA score has been suggested as one way that we may be able to identify patients outside the ICU with sepsis. And you need 2 out of those 3 criteria. presumed infection, and then you might be enrolled into a trial looking at sepsis. The difficulty with that is that it's not really been validated in the pre-hospital setting, and the paper which looked at this and the model development is available, and the only external validation data set which was available for the pre-hospital setting was that the KCMS data set, which only had 6,500 patients. And the AUROC, the calibration of QSOFA was actually not that great. It was 0.7. So perhaps it's at least something, and it may be a definition that we can think about using, although we would like to establish a data-driven definition in Victoria, which we might be able to use, but it's just to illustrate that QSOFA, although it's being held up as potentially one way of identifying these patients, does have limitations. So what potential antimicrobial agent would be used if we were going to think about giving a pre-hospital antibiotic? This was data from the ARISE study, again looking at the frequency of different infections. These are patients arriving to the emergency department with community-acquired infection. As expected, the most common sites of infection were in the lung, with community-acquired pneumonia, urinary tract, followed by soft tissue. Is there an antimicrobial agent or antibiotic agent which is currently available in the community, which can be given by paramedic staff or ambulance staff in the community for severe infection? And is it going to be feasible for them to give it in the pre-hospital setting? And the answer is yes, there is. So for clear meningococcal disease throughout Australia, paramedics within their scope of practice are able to give ceftriaxone intravenously, and after putting in a cannula. So we've given this some thought, and a group of investigators at Monash and in Melbourne are hopefully planning to undertake a trial of 2 grams of IV ceftriaxone pre-hospital for patients with suspected severe sepsis, a placebo-controlled individual randomized controlled trial, which is currently under review by the NHMRC, which is hoping to enrol over 2,000 patients into this study to determine whether early pre-hospital antibiotics in patients with severe sepsis is associated with a survival outcome. We think it will appropriately, hopefully, provide adequate cover given the relatively low incidence of resistant organisms in the community. There's obviously a tension in terms of the administration of antibiotics by ambulance staff prior to arriving to hospital in patients that are not actually infected. And that's a tension that obviously we're very aware of, and we're collecting a lot of data around the final diagnoses for these patients, in particular their microbiological parameters. But hopefully that will provide us one way of looking at this question about timing of antibiotic therapy and its role in informing patient-centered outcomes. So in conclusion, current evidence does suggest that appropriate antibiotic therapy should be delivered as soon as possible, and I've put that in quotation marks there because we are dealing with observational data, which is often confounded. Pre-hospital antibiotic administration represents an opportunity to test this, and is really not a significant deviation from current scope of practice for ambulance staff. But identifying these patients accurately in the community still remains a major challenge. Thanks very much.